Welcome to Season 6 of the Precision Medicine Podcast, sponsored by Trapello. This is the podcast where experts come to discuss the problems oncologists, reference labs, and payers face as precision medicine grows and consider solutions for advancing the quality of patient-centered cancer care. Be sure to subscribe at precisionmedicinepodcast.com to get the latest episodes delivered straight to your inbox. Hello, listeners. Just a quick production note, this is part 1 of 2 on prostate cancer with my gracious guest, Dr. William O. I hope you'll tune in to both episodes as they roll out together over the coming weeks. I'd also like to invite you to leave a review on Apple Podcasts, YouTube, Spotify, or wherever you listen to the Precision Medicine Podcast. And I hope you enjoy today's episode. Welcome back to another episode of the Precision Medicine Podcast. I'm Karan Cushman, your host and producer, and today we're focused on a type of cancer that is becoming top of mind for more men every year. In fact, here in the U.S., prostate cancer is the most common cancer in men, next to skin cancer, and the second cause of cancer mortality. About 1 in 8 men will be diagnosed, and for African American men, it's about 1 in 6. Across the globe, hello listeners out there, prostate cancer is the most frequently diagnosed cancer in about 112 countries, and it's the leading cause of death in 48 countries. Since 2014, we've been seeing a 3% year-over-year increase in cases and about a 5% year-over-year increase in advanced stages. Additionally, there are some well-known disparities in this area of cancer. Just as I mentioned, African American men have a 70% higher incidence rate than white men, often present at a younger age and with more aggressive disease. Of course, the statistics are concerning, but there is tremendous innovation happening in the science, technology, and medicine of prostate cancer. And I am incredibly honored to have with us today a leading mind and practicing specialist who is really at the forefront of this disease. He is a genitourinary oncologist and has decades of experience caring for patients with prostate, renal, bladder, and testicular cancers. He has authored over 400 publications and since 2003 has been listed among America's top doctors. He has held leadership roles at Dana-Farber Cancer Institute and the Tisch Cancer Institute at Mount Sinai Health. He's also served as Chief Medical Officer and Executive Vice President for the Prostate Cancer Foundation. Earlier this year, he was named chair of the newly established American Cancer Society National Prostate Cancer Roundtable and has literally now just returned home as director of precision medicine at Yale Cancer Center, professor of medicine in the Division of Medical Oncology, and medical director of the Smilow Cancer Hospital at Greenwich Hospital. Dr. William O., thank you for joining me on the Precision Medicine Podcast today.
Well, thank you, Karen. It's really my honor to be here, and I look forward to delving deeper into this really huge problem.
Thank you. Well, as you may know, and I know our listeners know, we like to start most of our episodes with getting to know our guests a little bit more, their career, their journey of how they got to where they are. And as I just mentioned, you literally just returned home to New Haven, Connecticut at Yale Cancer Center, and you attended Yale as an undergrad, I believe, a few years ago, but I read recently that you had said as a freshman, you walked onto campus eager to learn and to make a difference in the world, which obviously you've done in tremendous ways. But if you wouldn't mind, would you take us back? I know you're originally from South Korea. I'm curious what brought you to the U.S. and then led you to a career in medicine and even eventually oncology.
Well, thank you for asking. I was born in Korea. I came over as an infant with my 3 older siblings and my parents. We were new to this country, and we actually settled on Long Island because I had family there. And, as I was growing up, the question was, how was I going to make a mark in the world? It was really very daunting. It was a second language for my parents. They had an education in Korea, but we were really starting over in the United States. And I knew that medicine and science was a place where I could, in fact, impact the world in a way that I think a lot of immigrants think about education and science as a way to be objectively improving the world. And that's really what I came to Yale as an undergraduate at the age of 18 so many years ago to try to do. And I studied the science, but also always wanted to know how science applied to really human disease and suffering. And that's why I became a doctor.
I love it. Well, I have to say, personal experience right now, my daughter is a freshman undergrad. on the route to maybe being a doctor, she feels, and I'm feeling the pain of that.
Well, that's wonderful. I mean, it's a lot of anxiety, but it's always worth it in the long run.
It is, and it's a long road, and that's what she's faced with right now. But how does it feel to be back home in New Haven and at Yale?
Well, I'm definitely not viewed as a student anymore. I'm a professor. And so I think it's wonderful. The campus has changed. It's a very intellectually stimulating place, and the science and the physicians and really the students, just an amazing place to be. So I'm very excited because this role that I'm taking on allows me to continue my work in prostate cancer, but also to kind of try to bring precision medicine in cancer to this next level. I know this is the Precision Medicine podcast, and thinking about each disease, there are commonalities across all different cancers and across precision medicine writ large, but there's also specifics about diseases like prostate cancer that are really important to tease out because each geography, each disease, each person is individual. And I won't talk about politics, but we always talk about how politics is local. And I think it's true for diseases like prostate cancer. There's so many nuances to it that if you take some of the broader advances in healthcare and in medicine and in precision medicine in particular, there are applications of it in a disease like prostate cancer that we have to react to and really innovate. And you pointed out in your opening that we have work to do even as we make great progress.
Well, that is so true. And I think as we dive in, I just wanted to build on that and just point out that there are tremendous complexities here in prostate cancer due to the heterogeneity of the disease, but also because of the sensitivities and impact that it can have on lifestyle and the overall physical and mental health for men. We just covered colorectal cancer earlier this year, and with that, there was a big mental health focus. And I think this is another area where for men, we think of this little gland, the prostate, as just kind of this. We don't really think about it. What is its purpose? And so I really wanted to kick off the episode, Dr. O, with you just helping orient folks with the biology and anatomy of the prostate, and obviously prostate cancer being more prevalent now and the rise versus maybe other types of genitourinary cancers. Can you talk about the physiological structures that run through and are attached to the prostate and how all of this can have an impact on the daily function and lifestyle for men?
Yeah, the human body is an amazing thing, as we know, and sometimes we don't really think about the functions until something goes wrong, right? And the prostate's a very good example of that. Here's this small walnut-sized organ that sits right at the base of the bladder, right in front of the rectum. And as we know, we don't actually know what it does, Karen. It's one of those organs that probably is important for fertility. It may help process sperm so that men can father children, but it is really not clear exactly how important it is, except that over time we know two things happen. One is the prostate typically gets larger as you get older, something called BPH or benign prostatic hypertrophy. That is not linked to cancer, but quite common. Men have to urinate more frequently as they get older because the prostate typically gets larger. And the second thing that it does is it sometimes develops into cancer. And prostate cancer is definitely a disease of aging. It's much more common as men get older. And what causes it? Why that particular space is a little bit unclear. In fact, we don't really understand the true pathogenesis of prostate cancer. We don't really know what causes prostate cancer. There are a lot of associations, which we can talk a little bit more about. But in the end, this little organ causes a lot of trouble for a lot of men over their lifetimes, unfortunately.
Definitely. Well, let's get into one of your other recent roles at the American Cancer Society. I think they now have maybe 7 different roundtables that have been established,
That's right.
yes,
Yep.
over the past 20 years. And earlier this year, they decided to create a prostate cancer national roundtable. And you are the lucky chosen one to be the chair of that. And so I was hoping that you would help listeners understand why it's important to establish a roundtable now, and maybe what are some of the top 3 initiatives that you're hoping to work on specifically?
American Cancer Society is a very, long-standing and prestigious organization. All of us have heard of it. It's been around for almost a century or more. And the question is, of course, why now? Why prostate cancer? Why now? And specifically, there's 2 things happening, I think. One is the trends have been going in the wrong direction, as you quoted, both an increase in incidence and an increase in death, both in the United States and worldwide. is feared based on some recent epidemiologic trends. And I think the ACS really recognized that by itself, it's not going to be able to solve this problem. No single organization can. The government can't, foundations can't, academic medical centers can't by themselves. So the idea behind the ACS roundtables, and as you said, there are 7 of them, we're the newest one in prostate cancer, is to bring together organizations that all have a vested interest. So it's not just a single organization, it's really an organization of organizations, like bringing together the best of patient advocacy organizations, of scientific groups, of the academic centers, of patient-focused navigation groups, et cetera, to really try to help deliver the best possible outcomes for prostate cancer. And specifically, one of the things we've learned is, we talked about when I first started in this field. When I first started in this field at the Dana-Farber 25 years ago, there were no drugs that in fact improved overall survival for prostate cancer.
Wow.
Now we have over a dozen, which is very, very exciting. But it turns out that many men don't even get access to those drugs for various reasons. Maybe if you look at the combination of a hormone blocking drug that is considered a standard of care that improves survival in metastatic prostate cancer by anywhere from 20 to 40%, for which there are at least 5 drugs that are proven to be of value. In the United States, only about half the men receive it at the time they're diagnosed with advanced or metastatic prostate cancer. So it's problems like that is not just doing the clinical trials where the drugs get approved by the FDA. It's like, what do we do to get those drugs to the men who need it at the time they need it? And that is why I think ACS is really setting up the roundtable now, and why I'm honored to be the chair along with my 2 co-chairs. The ACS chair is Bill Dayhut, and the co-chair, the vice chair, is Yao Naemi from the University of Washington. And our goal with the steering committee and with this large organization is to really marshal the resources to try to focus on the problems that will solve this concerning trend. And some of the programs we're working on, even as we just launched in September, is to think about creating databases to be able to understand some of the trends better, because data is a big driver of understanding why, for example, men are not receiving the drug and where they are and what some of the barriers are to that, receiving the right treatments. And the other is screening, which is a very complex discussion. Screening is controversial for prostate cancer for reasons that remain unclear to me a little bit, but I understand why. The data is somewhat complex, and prostate cancer is a disease with a very long natural history. I'm sure we'll dive into screening a little bit more, but I think those are going to be 2 of the priorities for the roundtable.
Well, thank you for that. Yes, obviously we will get into screening more and the complexities there. And before we do, though, everybody wants to know, what do you think is contributing to this 3% year over year rise? Why are we seeing that in the 5% in advanced cases? Do you have any insight into those statistics?
Yeah, I'm going to start with the 5% year over year rise in advanced cases, because that's the most concerning. There's prostate cancers that are lethal, as you already pointed out, and they may not be the majority of prostate cancers, but they are the ones. That trend is the one that people are most worried about. And I think there is a general consensus that the death rate from prostate cancer, which had been going down significantly after PSA screening was first recommended, is plateauing and may start to go up. The Lancet Commission recently did a worldwide study that suggested that the death rate from prostate cancer may actually increase by 85% over the next 10 to 15 years worldwide. So I think that the backlash against screening and some of the concerns about over detection and over screening have probably led to more patients walking in with advanced disease. I think that explains the second number. The first number, why there are more cases in general, is an interesting question and one that nobody fully understands. There is an aging population, and you remember I started by saying that this is a disease of older men. So as we get older, and if we don't die of other diseases like infectious diseases or cardiovascular diseases, then we are at greater risk, if we have a prostate, of getting prostate cancer. But that doesn't always explain everything, because epidemiologists do what are really considered age-adjusted evaluations of the incidence, and the incidence seems to be rising even when you control for the aging population. And I think the short answer is there's a lot of these trends that we don't always fully understand. You probably covered the idea that we're seeing more colon cancer in younger people, and people have theories about it, but we don't really understand. Is this a nutritional thing? Does this have something to do with the hormones in our environment? Is it something to do with our lifestyle? There was just a recent article in the New York Times that said 3/4 of the Americans are either overweight or obese. These are the things that I think we don't fully understand because it's such a complex causation. And because I started out by saying we don't really know what causes prostate cancer, I can't give you an exact answer, but we need to really continue to delve deeper into it.
One of the things I want to bring up too throughout the episode is an interesting part of the statistics is the incident in African American men, because it is quite different. And that's where we'll start to get into some of the precision medicine elements, I think, too. But when you were part of the Prostate Cancer Foundation, obviously you did a ton of work there in this area. And this year, the Prostate Cancer Foundation, I believe, released new PSA screening guidelines for Black men in the US. I know you helped chair this review committee, and the findings were just published in the New England Journal of Medicine's evidence report. So I was wondering if you could lead us into a little bit of what we're talking about here today, which is the grave statistics, if you will, in the rise in prostate cancer, in particular for Black men, but also in the screening guidelines, how we're starting to look at these different components of prostate cancer differently and make our screening guidelines and the treatment of such more personalized, which is the precision component of what we're here to talk about today. So the question is, can you talk about the screening guidelines and how they are different for white men versus Black men today and the new reassessment there?
Yeah, of course. Those statistics that you quoted, when you look at them by race, by self-identified race, the trends are the most concerning for Black men. So there's always been a disparity. From the very beginning of the epidemiology, Black men have always had a much higher incidence and a higher death rate than white men and men of other races. And this plateau I pointed out of mortality, with a concern for rising mortality in the future as more advanced cases are being diagnosed, that disparity looks sharper again for Black men. In other words, the rate of rise of advanced disease seems to be higher for Black men compared to white men. So when I joined the foundation, I really asked the question, where can PCF make the greatest impact? And I think the same question is going to be true at the ACS Roundtable. What populations can we have the greatest overall impact if we are to recognize that we don't have limitless resources? And there are two high-risk groups that we've known for decades that have the higher risk of prostate cancer, both diagnosis and death. And that's Black men and men with a strong family history or genetic risk. We can talk about the second category in a minute, but what we decided to do is to convene a panel to look at the evidence for PSA screening in Black men. So we did an evidence-based approach to really assess, not just with randomized clinical trial data, which is the way most organizations, including the U.S. Preventative Services Task Force, remember that's the group that makes recommendations around screening, they have a very high standard, which I appreciate, which is randomized clinical trials. The problem is the men at highest risk of dying, Black men, are very underrepresented in those randomized clinical trials. They just are not part of that cohort. So we took a broader approach. We used modeling data, we used observational data, and we basically came up with a set of recommendations that highlighted some of the things that you pointed out in your intro and that we know. Black men, for example, are not only at higher risk of getting diagnosed and dying of prostate cancer, they're also generally diagnosed at earlier ages. And so it's not that other organizations haven't recognized this either, but I call it the footnote problem. They asterisk their recommendations for screening, and then they say Black men maybe should get screened earlier. And the problem with footnotes is it's hard enough to read those guidelines in general, but nobody's reading those footnotes. Doctors aren't reading them. The patients and the families are confused. So what we set out to do was to say, let's speak directly to this population. There may be biological and socioeconomic and cultural factors that contribute to this, but let's just focus on this population so that Black men in the United States who have the highest incidence and mortality from prostate cancer get advice from an expert panel. And I should point out the panel was from well-known academic centers, but also community health centers, urologists, primary care doctors, medical oncologists, and half of the panel identified as Black themselves. The idea was really, let's make sure that the community is represented, that this is not intended to be something from an academic perch where we're just telling patients and families and doctors what to do, that really we are using the evidence to drive home an approach for this high-risk population that might actually ultimately save lives. Because in truth, I'm an oncologist. I treat patients with advanced disease, But the place to make the biggest difference is really at the time of diagnosis or even before diagnosis. One day it's for prevention, but we're not going to be able to get to that conversation because prevention studies are, as you know, very difficult to do and a lot that we don't understand. If you don't know what causes the disease, it's very hard to prevent it. On the other hand, we do know that if we can screen high-risk populations earlier, we probably will have an impact on mortality. That has been shown in multiple studies, and that is what we set out to do in this guideline.
The Precision Medicine Podcast will return right after this.
With the explosion of new data and biomarkers in cancer today, how can healthcare professionals keep pace to know which genes will best inform treatment decisions? Trapelo knows. Trapelo is the first single technology platform used by oncologists, labs, and payers to resolve the complexities of precision medicine in real time. Trapelo knows which patients to test and when. It knows which tests are most appropriate, which labs are preferred, and which treatments are most likely to be reimbursed. Visit trapelohealth.com to learn how you can give cancer patients the most appropriate, evidence-based treatment options when time matters most. Dr. O, out of that study, I think standard screening guidelines as they exist today for non-Black men recommend that those doctor-patient discussions about baseline PSA testing should begin around the age of 50 to 55. What do or did the results of your study recommend for Black men? We know it's going to be lower, but what does that look like today?
Yeah, well, when we looked at the evidence, we found that basically, for reasons that are still not well understood, Black men tend to present earlier in life. And we recommended, based on that evidence, that Black men should begin conversation about this in their 40s, really in their early 40s, between the ages of 40 and 45, and that they should probably get what we call a baseline PSA at that age. And the reason for that was because everything shifted earlier in their lives, the chance to make a difference would be more impactful if a Black man had a PSA test between the ages of 40 and 45. We also recommended that Black men consider an annual PSA test rather than every other year or every third year, because again, data suggested that that would detect more clinically relevant cancers. And finally, we did also recommend that around the age of 70, they consider discussing stopping screening because they're diagnosed earlier in life. As you get older than the age of 70, there becomes an increasing risk of detecting less relevant cancers in Black men. So it's a conversation that is worth having at the age of 70 to perhaps stop screening.
I want to point out that in the Precision Medicine podcast, our audience is medical oncologists, patients, advocacy groups, industry, and we really try to keep it at a baseline as far as the science. And so I just want to recognize that I've noticed myself for the past few weeks when I've been having different conversations with folks that there's still a large percentage of the population in general and even diagnosed patients who don't really understand the concept of precision medicine and how it's influencing prostate cancer. In the green room, we talked a little bit earlier about biomarker testing, and just a plug for our last episode, ACS is doing tremendous work in so many areas. I had Hillary G. Geckner and Christine Ashcraft on recently. They are involved in the biomarker testing legislation effort that ACS CAN is doing. Yes. And so that was a really insightful episode surrounding the conversation over access to precision therapies through biomarker testing, which is definitely behind in our country. Dr. O, I was wondering at that high level, could you just give us some insight into how precision medicine, the concept of precision medicine, is influencing the way that we approach testing and treating patients with prostate cancer and enabling what we're hoping to get to, which are more personalized experiences and treatment plans?
Well, if you look at the spectrum, Karen, of prostate cancer, from screening to early diagnosis to treatment to a metastatic disease, there's a tremendous amount we've learned over the last few decades about how to risk stratify patients and how to really understand what drives specific types of prostate cancer. So I'll give you some examples. One, as you know, common misconception is that the BRCA genes, which were made famous by, for example, Angelina Jolie and breast cancer patients being advocates, is the most common germline mutation in prostate cancer. And in fact, somewhere on the order of, depending on the population you're looking at, up to 5 to 7%, maybe up to 10% of patients with advanced prostate cancer will have a germline BRCA or other DNA damage repair mutation. That number surprises a lot of people, and so certainly surprises patients, but even physicians are not always fully aware of this. And why is it important? Well, it impacts the decisions around, for example, how you might monitor a patient. We know, for example, that patients who are carriers of a BRCA mutation who have early stage prostate cancer may progress more aggressively. We also know that they may express less PSA, so you may not be able to rely on PSA as much. In the advanced patients in metastatic hormone-resistant or castration-resistant prostate cancer, we're seeing that those patients are candidates for PARP inhibitors. And there are multiple PARP inhibitors that have recently been approved for treatment in this population with both BRCA1 and 2 mutations, but also more broadly DNA damage repair or HRD mutations. I think there was a recent paper that came out that showed only about half or less of patients actually get tested for it, either in the germline or somatic testing. So it is, I think precision medicine is something that we were very excited about with the first human genome project and sequencing. And I think some people maybe felt like they were gypped, that whether there's doctors or patients with cancer, that it doesn't influence or help many patients. And we know that that's still a challenge. I just quoted numbers that are very low for men with prostate cancer who may carry, for example, a BRCA mutation. But we also know that if you don't test, you won't find those mutations. And we also know that that makes you not a candidate for some of these drugs. And those drugs can have profound benefits in these patients, not just survival benefits, but improve their quality of life and alleviate symptoms. You didn't say it in the intro, but I recently joined, well, you said it in the intro, I'm sorry. One of the reasons I joined Yale and wanted to be the director of precision medicine for the Yale Cancer Center was not that we've done everything that we have to do. It's really to think about precision medicine 2.0. Is it just an implementation problem? Is it just a technology problem? Or is it some combination of both? And one of the things I learned when I was at PCF was it really is a combination of both. You've already pointed out that people don't understand the concept of biomarkers. Many physicians are not ordering the tests at the appropriate time. We know that from real-world evidence data. I really appreciate and understand that. I feel badly for doctors who have to know so much about so many cancers. The general oncologist in practice has to understand all of these different biomarkers for so many different disease types and so many new drugs that are coming down the pike all the time. I do think that we are going to need information tools that help doctors to really process that information in ways that allow them to make the best decision, not replace them, but really allow them to make the best decisions by summarizing all that flood of data. And that is the only way I think we start to improve the implementation of precision medicine care. In the meantime, what's coming down the road? It's more antibody drug conjugates, it's more radioligand therapies, it's more targeted treatments, it's more precise immunotherapy. So I think we're going to keep moving forward, but we need to tie the treatment to the patient's particular type of cancer, whether it's screening for the cancer, whether it's treating the cancer, whether it's diagnosing the cancer.
When you say the word implementation, I think there's a lot packed into that. I think we're at an exciting time, obviously. We're going to talk about AI later, but just getting back to the data piece of it, there are so many elements of excitement, but also feeling like we're behind. Just to go back to an earlier part of our conversation where we were talking about African American men, it seems like we're at this great time where all of this stuff is happening. Precision medicine has been around a while. A lot of people don't know about it. But there are tremendous advancements in the therapeutics that people are benefiting from. But when you look at the African American population in particular, and you look at the data and the innovations that are happening, they're only represented, I think, maybe I have this wrong, but 1% of that data is representative of the African American population. So in some respects, we have a long way to go before maybe we'll never get to this place of normalization, but I think it's going to start to happen faster and faster as we do have things like AI that enable us to catch up a little bit, and that we do have tools in the flow and at the point of care that are helping physicians, make those decisions. Hopefully we'll see some of that compression happen, and it won't take us so long to get to a place where some of this is normalized. Hypothesis, but
No, I think that's right. And if you think about it, there's so much genetic diversity in the United States and around the world. And as you point out, a lot of genetic data that does exist, whether somatic or germline, exists in Northern European populations. There's this interesting phenomenon of Asian women, non-smokers, getting lung cancer at higher rates. Do we really understand what drives that? And the short answer is, of course, we don't understand it the way we would like. And part of that is that, for example, in the United States, they may not be part of a typical screening program. And I think that you see this similar example in prostate cancer. There are obviously the Black men in the United States have this very high risk, but there's other populations that we don't fully understand. And it is that complexity. I think genetic testing has gone way down in price. We know this. The ability to get these tests, the price is no longer the problem necessarily. And I think the genetic testing is going to continue to become less and less costly. The real problem is the information. It's the sheer volume of the information. And, as a clinician, I always remind people, even all that genetic data has very little value unless you can link it to what happened to groups of patients. In order to understand that heterogeneity, that in order to personalize treatment, we have to understand both the genetics, but also the clinical outcomes of those patients and tie those pieces together. And people are doing it, and we're getting there. I think the more and better tools coming, but I think what we have to get to is a point where I, as a physician, seeing a patient walking into my office, what does that person need based on the genetics of their germline genetics, their somatic genetics of the tumor, based on their medical history, based on their socioeconomic background, all the pieces. We'd love to have this kind of multi-omic approach that includes all the data that we know impacts a person's outcome, cancer outcome. And we're not going to get there right away, but I think that is what precision medicine 2.0 is.
Absolutely. I kind of think like we're getting our arms around it. It feels like we're getting our arms around it. It's still really big, but it would be amazing if there was this funnel that would lead right down to the oncologist right when he's making that decision, and the world would be perfect and that patient would get the exact right screening and everything they need.
Exactly.
Right? Well,
Yes.
so with that, let's look at that. So as we get into the science of things and the precision of things, and we look at the molecular and genetic and epigenetic drivers of prostate cancer, and just as you mentioned with the Asian women and lung cancer, let's look at the differences and the biological differences maybe between white and African American men as we look at that genetic makeup. Can you talk about, how those are different and what's different about the aggressive tumors as well?
Yeah, I think there's a lot of interesting stories there that are being teased out slowly. There's two different camps here. There's a camp that says that this is primarily socioeconomic and cultural. Like if you go to the VA and you look at screening or treatment studies in the VA, which is an equal access system with a large proportion of African American men with prostate cancer, they seem to do just as well or better than white men in that setting. That suggests that it's an access issue if you get in and insurance and cost is not a factor. But there's also more than that, I think, and that is this idea that the cancer itself behaves aggressively. And some of the most interesting data is this kind of epigenetic component. Epigenetics, of course, is what happens to the DNA in the environment that you're living in or that you're exposing, let's say, your normal body to or your normal tissue to. And we know from some studies done in certain inner city environments that just the stress of living in those environments, maybe it has to do with the air you're breathing, maybe it has to do with chronic upregulation of things like stress hormones, but somehow it changes the DNA in ways that are measurable epigenetically. There was a very interesting study that we did with the World Trade Center. And again, this was a terrible tragedy in New York City, as we all know, where many men were exposed to the toxic fumes of the 9/11 World Trade Center site. Prostate cancer is one of the diseases that was actually increased in incidence, even after controlling for many other factors. And we did a study that we published several years ago that looked at men with prostate cancer who were first responders compared to a control group of men with the same stage of cancer and the same grade of cancer, but were not exposed. And we found these interesting kind of inflammatory markers in the tissue. And we did a parallel study in animals that were exposed to World Trade Center dust that was saved by a group at NYU. And we found the same inflammatory markers, these kind of negative effects of inflammation, even after a short period of exposure to these rats, these animals. And, we looked at their prostates. Obviously, they didn't get prostate cancer in that very short time, but they had the same inflammatory markers. After breathing the dust, it went to their prostates. So it was very interesting because the question is, what we were trying to get at was, how did exposure to that type of toxic waste for first responders, which was, again, a terrible tragedy, because I think, many of these brave heroes went right to the site to do what they had to do, and they were unfortunately not given the right advice about protecting themselves. And the incidence of prostate cancer is clearly higher in those men. So the lesson that I want to learn from something like that is, as a scientist and as a prostate oncologist, is what other exposures can we avoid? What other risk factors are there for taking somebody who otherwise had a moderate risk of prostate cancer? And if the environment's going to increase that risk because of some exposure, then we have to figure out what that exposure is and avoid it or get it out of the environment. So I think, going back to the Black men, we know that Black men live in disproportionately in communities where there's poverty and there's crime and there's other factors that might be affecting their risk of epigenetic change that might be contributing to their prostate cancer risk over the long term. So I think the science will continue to progress, unfortunately not as fast as we'd like. That's why we rely on tools. People will say, well, PSA is a terrible test, and I would really disagree. PSA, the reason we keep using PSA is that it's actually not a perfect test, but it's a very good test that we have to improve and have improved. And in fact, that's exactly what's happened in prostate cancer. We have multiple biomarkers now from multiple companies that help us to understand and predict the behavior of prostate cancer so that we actually can apply the right treatment to the right patient even after they're diagnosed with prostate cancer.
Well, I think that's a great segue into understanding risk and really early detection, because obviously many men are asymptomatic and this is not top of mind. We just don't have those types of guidelines that are like breast cancer, where women are going in every year. I mean, it's just more talked about, and maybe prostate cancer is getting there, but I think it's much harder to detect without going and seeing a physician. You can't just feel it. Do you feel like there are sufficient standards in place for, first of all, looking at family history and just basically having those conversations with your primary care doctor? Are patients and doctors having enough or going deep enough to feel like, okay, that is getting recorded in the chart? And then are they having that conversation of, when is genetic testing important? And let's not even talk about cost, because maybe we're not there yet, but just that information. Do you feel like there are sufficient conversations and standards in place where those things are happening early enough so that we can really enable folks to be in that early detection space?
Unfortunately, I think we've made a lot of progress, but we're still way behind. And I think if we look at the right model, it is breast cancer. I always say breast cancer and breast cancer advocacy is 10 to 20 years ahead. I think what men are catching up. I do. I've been practicing for 25 years, and men are definitely much more aware of their bodies and of asking the right questions. It's gotten better, but part of this issue and what you're getting at is that I'm an oncologist. We have to get back to the primary care doctors, and this is one of the things that the ACS Roundtable wants to focus on, which is, how do we get organizations like the American Academy of Family Physicians and the American College of Physicians and primary care doctors to do exactly as you said, which is to buy into the idea that this conversation has to happen. Now, this is happening in the context, as we know, of people leaving primary care fields and concierge medicine, and it's really challenging. And that's part of why I think the only way to handle this is for patients themselves to be educated. I think in some ways we have to skip over the doctors sometimes, because doctors are put upon and they may have a lot of strong opinions and they may not always understand the data. I think we have to do all of the above, but I think going straight to patients and going straight to primary care doctors to be able to put some of those standards in place more effectively, I think is important. Even as urologists tend to be strong advocates for screening and understand some of these risk factors a little bit better. Obviously, oncologists like me are typically only consulted when the cancer is fully diagnosed, and often when it's advanced. I don't want to be involved if there's a chance to cure the patient early on. And I do see many of these men. I'm an unusual prostate oncologist in that I see patients at the very earliest stages of prostate cancer because they're looking for advice from me. But that is the right space to look. I mean, there are a lot of advances in treating metastatic prostate cancer, which is great, and we can talk a little bit about that. I think it's an amazing space right now because so many new drugs and so many new treatments, but they're not curative. These patients suffer. So if I had a choice and I had a magic wand and I could make things better, I would find more of these cancers earlier and find more effective ways of eradicating the cancer before it ever got to this advanced metastatic stage.
Well, I think the message in there obviously is for patients, for doctors to make sure, realize that everyone's looking at their watch these days, but that family history component of things is super important. And maybe you don't even know what it is yet, but maybe you need to talk to your father, your grandfather, have those conversations to really kind of understand where you are, because we are at a place in medicine today where that information can be life or death. Thank you for joining us for part 1 in my conversation with Dr. William O., Director of Precision Medicine at Yale Cancer Center. Coming up in part 2, we move into the latest diagnostic tools, precision therapies, and the role of artificial intelligence in prostate cancer. We hope you'll tune in. You've been listening to the Precision Medicine Podcast, sponsored by Trapelo. Trapelo is the first clinical decision support tool to align the interests of oncologists, labs, and payers to give patients the best chance at beating cancer. To learn more, visit gettrapelo.com. To subscribe to the podcast or download transcripts of any episode, visit precisionmedicinepodcast.com. We invite you to join the conversation on social media. You can find us on Twitter at PMP by Trapelo and on LinkedIn at the Trapelo Company page. If you know someone who would enjoy the Precision Medicine Podcast, please share it. They'll thank you, and so will we. We hope you'll tune in for the next episode.